Very impactful.
You can keep calling me the new guy as long as you want. Folks, some sort of a honeymoon period. I'll take it as long as I can get it. Thank you guys for coming out tonight. It's an honor to be with you, and it's an honor to present tonight's speaker. So, as President and CEO of UNC Health Blue Ridge, it's an honor to introduce to you this evening Colonel Stephen Coffey, a distinguished leader whose impact spans military service, healthcare advocacy, and academia. Colonel Coffey plays a vital role in shaping the future of our Air and Space Force personnel, assisting the Deputy Assistant Secretary in formulating strategic plans and policies for the 700,000 military and civilian members who serve our nation. His leadership ensures that these individuals and their families receive the guidance, support, and resources they need in areas such as human resources, compensation, education, training, and organizational development. A graduate of Morehouse College, Colonel Coffey began his distinguished military career through the Tennessee State University ROTC program and has since earned multiple advanced degrees, including a master's in legislative affairs from George Washington University and a master's in clinical quality, safety, and leadership from Georgetown University. A testament to his lifelong commitment to learning and excellence. He also holds a certification in diversity, equity, and inclusion from Cornell University, underscoring his dedication to creating inclusive and equitable environments. Beyond his military role, Colonel Coffey is a healthcare advocate, president and CEO of Head to Heart Connections LLC, and a leader in patient safety initiatives with the World Health Organization and MedStar Health. He serves on multiple advisory boards, guiding policies in healthcare research and aviation safety. An international speaker, accomplished author, and educator, Colonel Coffey continues to inspire change and innovation. What a privilege it is to have him here tonight in Morganton. Please help me in welcoming Colonel Coffey.
That's quite the introduction. I want to meet that guy.
Wow. Thank you so much for the opportunity to be here. I gotta tell you, anytime I can be outside of DC, it is a fantastic day. So I am truly honored to be here. My mother is deceased now. She used to say there are two words that we don't use enough. The two most underutilized words in the English language are thank you. And so I'll start by first saying thank you to Gary. Thank you so much for the introduction. Dr. Frank for the beautiful just time here. Laura, and one of those persons who doesn't mind playing major roles in minor parts, because I know these types of events don't just happen. There are people that play those major roles in minor parts. Janet in the front office over there who helped me get here. But really for the entire team that's really hosting you today, this has been absolutely a fantastic event. So just want to say thanks for that. Food's been great. And I'll tell you, North Carolina, you got discipline. So this is the clicker. I'm going to try to do this. If I mess it up, then lay it on my staff. So, first, couple disclosures that I'll say. You can read that as you leave, but it essentially says that the views that I express tonight do not represent or reflect the United States Air Force, the Department of Defense. They're solely my views. And so you also hold the clearance for that. With anything that we do, we generally want to start with objectives, and in the military, we generally have a very standard way of briefing. We start by telling you what we're going to tell you. We then tell you, and then we wrap up by telling you what we told you. So I won't stray too far from that particular thing, but before I really get into the meat of this, I wanted to highlight an organization that myself and 9 other titans in the field of patient safety and advocacy started, called Patients for Patient Safety US. And so, as you can imagine, when you have a kitchen table issue where you're talking about patient safety, you're talking about medicine, you're talking about harm that's occurred, all of us experience medical harm or diagnostic error in some shape, form, or fashion. And we decided we have to do something to really elevate that patient voice and the importance of having patients involved in the process. And as such, we started the U.S. chapter of the World Health Organization's Patients for Patient Safety. And what's interesting about that is that we didn't just start an organization just to advocate and use our voices, but we decided we needed to do more than just talk about the problem. So the first thing we did was write about the problem. And we had these provocatively titled articles, for example, Who Killed Patient Safety? Something that's very provocative. And I can tell you one time I was doing a presentation with CMS and they were very reticent to let me go up and talk. And I said, here's the topic of the talk. It's who killed patient safety? It's not an indictment, but it's something that we need to elevate and expose that we have challenges that still persist within our health system. But not only did we talk about things and write about things, we started to partner at the local level and at the national level. I had an opportunity to give briefings at the White House this past September on the World Patient Safety Day and highlight some of the efforts that the Biden-Harris administration had undertaken as we started to really elevate the patient voice and involvement to get after how do we solve these challenges within safety? How do we solve these challenges within healthcare in our system? We've worked with the President's Council for Advisors of Technology. We're working with a new thing called Project Pivot, which will utilize patient voices and their experiences to really impact HCAP scores. And so a new way of measuring how we have patient experiences and showing the meaningfulness of that. But not only did we do things with our voice, not only did we do things with partnership, we also did research. Because we're in a field of study that requires us to have data. We can't just have good stories. Everybody wants a story, but you're always like showing the data. There's a sign that used to hang over the Secretary of the Air Force's office. He says, "In God we trust, everyone else bring data." And so that is truthfully how we approach this idea of improving safety and quality within medicine. And so we have a number of partners that are with us, institutions, and so my ask and plea for you in this room, this health system as a whole, is that you would join us. Go to pfps.us. It is pfps.us, and have a chance to look at some of the things that we do. You may join as an organization, you may join as an individual champion, and it doesn't cost you anything, it doesn't commit you anything beyond the fact that says, I have this commitment to improving patient safety and patient quality as an individual. So, as we get to the story and the experience, I wanted to start with a little bit of what I call a coffee break. If I think about it, that's obviously a play of my last name, right? That's a coffee break. So we'll play this video, and then we'll get a chance to go back. favorite author was Charles Dickens. He said it was the best of times. It was the worst of times. It was the age of wisdom. It was the age of foolishness. Those words never rang more true than the birth of my son, Stephen Hawking II. In his life, my life would change forever, and the world would be introduced to a living miracle. So Stephen was born September 28, 2012, and I was so excited because I knew I was going to have a son to carry on with the good name. And if you look right there, you can actually see that's my hand. It's cutting the umbilical cord. And I think all the doctors gave me this dull pair of scissors because it's a lot more difficult to cut than what I saw on YouTube. I don't trust me. But I was excited because I knew I was going to have a son. And when the nurses came in, they took him away. They ran their normal newborn screening test. And they came back and they said, well, he's got this sort of a high bilirubin level. It's a little bit jaundice and he has a low glucose level, but they assured me he would be okay. And so that really sets up the evidence for this story because I had this full faith in the medical system. And what we found later out through his experience, what you'll see here as we kind of walk through his diagnostic experience through the National Academy of Health and Medicine, the diagnostic process, you'll start to see these visible gaps and seams in medicine. So recall Stephen is born, we've got him at home, we've been giving him milk, he's sort of throwing up a lot, there's a lot of episodes of immune system going on, and we're not quite sure what's going on. His bilirubin is still high, we put him under the lights, it's still high. And one day we get a phone call from his pediatric provider, who was at our small hospital. And she says, Stephen has galactosemia, you need to take him to the larger hospital. Now I put this provider on a speakerphone. And my intent of putting the provider on the speakerphone is that my wife and I could hear the same message, so we have a clear understanding of what we need to do. She says, go down to this larger hospital, tell him he has galactosemia. And I'll pause right there for a moment because I want you to start to understand and see the barriers in communication. There's a barrier of communication because the provider had a very pronounced accent. There's a barrier of communication in that the provider told me, a layperson, to go to a larger hospital to tell them about this complex condition called galactosemia. Now, for those who just may not remember or need a refresher on this, galactosemia is a metabolic condition whereby his body is missing the GALT1 enzyme and cannot break down the simple sugar galactose that's found in human and animal milk. So, in essence, his mother's milk was damaging his liver, unbeknownst to us. And so I go down to this hospital, and in my broken English here, my broken medical language, because Dr. Google is not that great in 2012, I'm trying to tell these scores of doctors, here's why I'm here. And what I found out after going down here, they run all these tests and they said, no, it's not really full of galactosemia. It's just a trait. Like sickle cell, you just have a trait. It's not something to be concerned about. Don't change his diet because if you do, he will have challenges trying to digest milk later in life. And they discharge. And as soon as I get home and I'm discharged, the thing that I find out is that the hospital, my small hospital, called me. So it's ironic, considering it was at the same time that we got a phone call on the day we were discharged. And they said, stop, don't give him any milk. And I said, wait, you told me to go to this larger hospital. The larger hospital said, it's not galactosemia, we don't need to change his diet, continue with what we're doing. And the smaller hospital, despite having the correct diagnosis, said, refer to the larger hospital. Size does not always matter in medicine. You fast forward to Thanksgiving, and so I'm a shopper now. I am. You go in my closet, I am a shopper. Right? Shopper. And so I am ready to go out on Great Thursday and get my Black Friday shopping ready for my son's gonna get his first Christmas, I'm gonna buy some stuff. I'm in Walmart, dressed in my comfortable clothes, I've got on my hoodie and I'm ready to do battle. Ever done Black Friday shopping? You gotta box out a little bit when you're up there with the TV. So I'm over here, there's this lady who happens to be in a wheelchair. She's trying to get this last G.I. Joe to come to her. And I may have pushed her a certain way so I can reach above her. But I'm in the line, I'm not looking back at her because she looked at me like, you already know. And then I get a phone call from my wife, and she says something is wrong with Steve. So now I'm mad because I gotta give her this G.I. Joe to come from her that I push her out of the way again and go home and find out what's going on with my son. So my wife says he's got a lump on his leg and we need to go to the hospital. Now understand that I only lived 2 minutes, and I'm not talking in hyperbole or exaggerating. I was 2 minutes from the hospital because I was right outside the gate of where the hospital is. So access to care was not my challenge. And we go to this hospital, and I'm in my comfortable clothes, and the doctor looks at me and he says, your concern is really not that bad. It's just fatty tissue. It's a swollen lymph node. Don't worry about it. You're overreacting. You're an overreactive parent. So my concern was disregard. You fast forward beyond that, and what I find out is that he was really sick. And on November 28, 2012, we were sitting in the PICU at Georgetown University Hospital. Now understand, I didn't even know that the PICU is where we send really sick kids. I know about ICU, but I've never heard of the PICU. I didn't know that's where we send sick kids. And this resident, why I appreciate the residents so much, this resident tells me, this is Stephen, our 2-month-old from an outside hospital. His permanent liver failure, secondary to galactosemia. And then 5 days later, Stephen had a transplant. Youngest in the country at 8 weeks old, to have a liver transplant. And as we've gone past the transplant stage, he's now thriving and doing well. We published a book called Baby Stephen's Good for Life. And he's doing relatively well, still up and down days, but overall relatively well. But his entire experience causes me to have these what-if questions in my mind. What if the doctor who saw me didn't disregard me because of the way I potentially look or anchored in the lines? What if the doctors at the larger hospital were more concerned about a conservative approach to diagnosing and treatment? What if the doctor called ahead and told them what galactosemia was? Because I'll tell you the greatest regret that I have, and continuing after this day, is that I could not do something to save and protect my son. I protect our country every day. I'm deployed into the Middle East for over a year, protecting this country, but I could not in that moment protect my son. And that's something that I do. And so when I think about that, the thing that you start to hear and understand throughout the experience is that I felt that I wasn't heard. And I think a lot of patients have the same feeling of, I'm not heard when I come to the doctor. But not only that, IHI, because, you don't just throw up comments without putting some data behind it. IHI did a study, and it said that the most common contributing factor to patients feeling like there's error is they didn't feel like they're heard. It's a perceived error. If I go into the hospital and I say something is wrong with this part of my body and you don't even listen to me, because you know clinically it's not what I pointed out, then I feel like you're not listening to me. I'm not a part of this care team. And if you think about some of these other things that kind of pop out of the story, access to care, again, I was only 2 minutes away from the hospital. Access was not my challenge. But there is a problem for some of those who have transportation and security. I felt something was missing in the diagnosis. I come in with this, my son has this lump on his leg and it doesn't make sense to me, but I'm still not regarded as, that I know what I'm talking about. When I look at this idea, I don't know who to call. When I have this conflicting diagnosis between hospitals, between providers that I put my faith and trust in, I don't know who to call. The confusing, conflicting information, the differences in the diagnosis, it's a trait, it's a full-blown galactosemia. What do I do? Now, the thing that I want you to understand is that patients have this very different taxonomy for talking about medical error, for talking about the concepts that we see in medicine. And so it's important to understand that when you're engaging with patients, that they don't speak the same language, and we all have the same intent, wanting to be better, wanting to be like a partner in care. Now, if I were to tell you to caption this, and I actually did this with my son as I was prepping to come down here. I said, son, tell me what you see in this picture. And he said, it's a giraffe that's painting a hat. I said, well, it is that, but it could be a giraffe that's painting a woman. But it's all about perspective. It's all about perspective. The patient perspective. The perspective of the provider. The thing that we start to understand is that patients provide you with a perspective that oftentimes is known through experiential knowledge. So I do not know what it's like to have a liver transplant. I don't. I don't know what it's like to have a diagnostic. I don't. But I can tell you what my son's AST, ALT, GGT, bilirubin, what he reacted to and how he felt when his program levels were increased, when they decreased, when he had cholangitis. I can tell you all of these things because patients and their families see the entire movie of care. But you as a provider will only see the 15-minute trailer because you have other patients to see, you have other responsibilities to do. And so it's really important that if you understand that we start to include patients into this idea of the data points they bring to care. Now, the thing that I will tell you is that patients actually help us to identify some of those blind spots that are just really around us. Now, Jahari's window was actually named after two psychologists, Joseph Luke and Harry Ingram. In 1955, they made this whole diagram of what a blind spot is. And so they talk about first that there's information that you know about, the information that you and others know about you, and that essentially is just shared information. You all know this kind of stuff. There's information that you know that others don't know. They call it facade, I call that your secrets. That is strictly your secrets. There's information that is unknown to you and others, and that's just the unknown. But the sweet spot is that information that others know about you that you don't know. Now, I know, not down here in UNC, not in Worthington. That's called, gossip. We only did the DOD. We only been down here. It's only the DOD that you gossip. But really, that sweet spot is understanding that blind spot and then what patients can bring to fill in the gaps and the holes that are in that blind spot. So I really want you to understand that don't just disregard a patient because they don't have a clinical background. Understand that they may help you identify something that is really hidden in plain sight. And so I think when you start to look at why we make patient safety changes, why do we have changes in medicine, I mean, this is not something new. The Institute of Medicine pushed out the report and said it's error is human, and we see that thousands upon thousands of people died in 1999, and we still have thousands of people that died in 2025 from the same thing. And so when I think about that, and I ask myself, well, why is it that we can't seem to change? And someone in the back is probably asking, or scratching their head, let's get a sheet. There's always one person that was going in that says, why do you have a police car, an ambulance, and a fire engine on a slide? What does that have to do? And this is how I equate that to. So, what many of you may not know is that there are 7 different types of sirens that are actually used. 7 different types, and we'll talk about it later. 7 different types of sirens. And each one of those sirens has a very distinct and different sound to the siren. In 1970, or prior to 1970, it was not a mandate that we had electronic sirens on emergency vehicles. What we found is that they used to have a bell, but as the cities grew and the populations grew, the bell became insufficient, so they had to figure out something else. What we found in a study from NYU is that they found that emergency vehicles that had a siren actually got to their destination in about 11 seconds, whereas the ones that did not have a siren got there in about 14 seconds. So simply put, sirens save lives. Very simple. Now, how this relates to patient safety. And so what I think about is police call. It has a very distinct siren. You've probably heard one before. But it has what's called a high-low sound, right? It's a high-low sound that it uses. And the police car, as you see it, is oftentimes running to someone. She's running to the scene of an accident. She's running to the scene of a crime. If I put that into the lens of patient safety, the siren of the police car, we're running to the event review. We're running to figure out what the root cause analysis is. We're running to something, somewhat reactionary. The sound of the ambulance is one that is a mix. It's kind of a high-low wail. Right? The sound of this ambulance is one that is always running from something, running from the accident to take you to the hospital. And what we find if you look at that in the context of patient safety, we're oftentimes running from including patients as partners because I see the value of it yet. I'm running from getting those perspectives that are sometimes hard to hear. You may have a patient and family advisory council, but I don't want you to give me, really good dialogue and information. I want you to give me confirmation. I want this patient and family advisory council to only sign off on what I've done is good. I'm looking for confirmation, not information. But the sound that I would tell you to key in on is the sound of the fire engine. And so the fire engine has a wail that is a mix of both the high-low pitch that it has and the repetitive sound that the ambulance has. And this wail is one that really does cause you to move. If you've ever heard the fire truck moving, you will actually move out of the way for a fire engine without ever seeing or knowing what the catastrophic event is. But because you hear this sound, you know I need to move. And I've talked to a number of first responders and firefighters will tell you that they spend more time doing fire prevention than actually putting out fire. And so I think when we talk about the context of patient safety and why this matters, maybe the reason why we've not had much movement, or not as much movement as we should have, from 1999 and the IOM to now, is that we use the wrong siren. What does siren sound like for patient safety when we're talking about fire prevention? Fire prevention is open notes. Fire prevention for patient safety is being inclusive. Fire prevention for patient safety is respecting that patient's perspective as a part of the care team and not just someone who's a consumer of care. So I think the other part we have to look at is that when we look at these patients and partner with them, we have to think of them as resources. Now, I'll tell you that resources are, there's only about 4 things you can do with resources. You can spend resources, you can waste resources, you can save resources, or you can invest resources. And I put that into, again, the context of patient safety and advocacy. And I say if we're spending a resource of a patient, that patient comes in with care, and it's very transactional in nature. They come in, they receive care for whatever is going on with them, and then they leave. Irrespective of how they were treated, irrespective of what they could have brought to make this process better, it's transactional in nature. We can waste resources of patients. Patient wants to come into the hospital, they give you feedback, they tell you that blind spot, and we ignore that blind spot because it doesn't fit into what we want. That's the less desirable populations. We don't want to engage with them and understand their perspective because it is a real perspective as well when they come to the hospital. We can save the resources of patients. We have these patient and family advisory councils, and they're there for ornamentation. I want to show everybody that we have one. But I don't want to really use them because I just want to show you that we have one. But the real secret is when we invest in patients. The real secret is when we take those patients and we take those experiences that they have and we decide that I want to partner with you. I want to understand your perspective. I want to understand that blind spot that I don't understand and see that's apparent. I want to have events like this where we bring people from the community, people from the hospital, leaders in to have very thought-provoking and very real conversations about the challenges that are in front of us. That's how we get through the patient safety. Now, many of you are old enough to at least have heard of Rip Van Winkle. I was again prepping and my son asked me who was Rip Van Winkle. I'm like, son, you just remind me every day, don't you? Every day. But for those who may have forgotten, so Rip Van Winkle was a story written by Washington Irving. It was published in 1819. A Dutch-American villager who meets this mysterious man while hiking through the Catskills Mountains, takes this purple elixir, drinks the elixir, and falls asleep for 20 years. And as I was kind of looking at this, I said, well, what if 20 years turned into 25 years? Because that's how long it's been since this medicine published. It turned into 25 years. When we found out at the end of Van Winkle's story is that he woke up and things had changed. He ran into a subject on the street. He says, well, who are you loyal to? And he's thinking that the subject's going to say King George, but King George is no longer in power. There's change that happened. And he finds that his beard is really long. He's built out of place. His clothes don't fit right. And I give this metaphor because I think there's a lesson we can learn from the Rip Van Winkle field. That one, change happens over time. And if we don't adapt to change, we don't recognize how change is, we will get left behind. It's the awareness and attention that the world around him was different, that he had to think different. Because if we stay stuck in what's worked in the past, we'll always be stuck. If nothing changes, nothing changes. It's this awareness that the community has a responsibility. As he ran into that young person who actually was named after him, it was his daughter or something. The community has a responsibility to be involved. And lastly, the consequence of neglect. If you don't act, if you don't change, nothing will change. And patient safety will be in 2050 where it was in 2025, where it was in 1999. And so we're charged and called to act. The last is a person by the name of Kim Landon, and I wanted to play a bit of her story.
On June 11, 2001, the thought was that I had developed a blockage somewhere between my kidneys and my heart. I was taken down to the cath lab, and 4 seconds after the injection was given, I went into anaphylactic shock. I coded, I was defibrillated 3 times, and since that day, I've had 12 surgeries, 2 were emergency surgeries, over 100 admissions in 5 different hospitals, 4 different systems. It's been 12 years since my episode. If I had only been the patient man that I am now. It's amazing to see what patient engagement has done for my health. I know my medicines, I know my medicines. I know my body. I understand me. I have no problem talking to my providers, and they have no problem talking to me. And I'm excited that my providers are listening. We're on my team together. Each interaction with my providers, I have questions. I make sure that I understand the plan of care before we leave each other. I know my responsibilities and what I'm looking towards them to do. I am a totally different patient. I have been activated and engaged. I now have the confidence, the skills, and the ability to handle my health care. My hospital admissions have decreased, and my health has improved. I know it's because I'm engaged. It was the right thing to do. Patient engagement is my camp. It lights the way to better health care, better outcomes, and safer care.
I talked to the residents today, and I left them with quote by William Austin that said, "A good physician takes care of the disease. A great physician takes care of the patient who has the disease." So I think that as we collectively partner to really advance this cause of patient safety and quality, we do that in partnership. And thank you so much for your time, and I look forward to the panel session.
Thank you, Colonel. We can ask the panelists to come on up here. While everybody's getting settled there, I want to say, I was glad you brought this up, a few thank yous this evening, but before we get too far along with this. I've done a couple of events here, so the comm staff is always wonderful. They are behind the scenes. You really don't see them right now. You can see them while they're setting things up. I really appreciate the work that they do. Thank you to the medical staff for hosting, for coffee, and this group of panelists. I want to thank the panelists, especially for getting the award going the longest way for dinner tonight. So certainly, marketing and business development, including I see Tony up there trying to hide, but he has done audiovisual, he's done photography, he does everything, and medical staff office as well. So let's give those folks a round of applause. So I've got a bunch of questions. I don't know what I'm going to ask them to get really interesting. But as we go, panelists, when I ask you a question, just go ahead and leave with who you are, why you're here, kind of thing, so we don't spend a lot of time with long introductions. Tim, we'll start with you. We're going to give Colonel Coffee a little bit of a break so he can enjoy his water and catch his breath for a little bit. But as a hospital board member and advocate, talk to us a little bit what drives your passion for this kind of work. What do you see your role in ensuring both equity and safety
Thank you so much, Thea Yang. And before I answer that, I do want to thank Laura for allowing me to bring my parents here. They influence a lot of the advocacy work that I've done. And I realize both their primary caregivers are here tonight. So this is very interesting. Now, when I was asked to be a part of this panel, I really thought about these questions and I wrote a lot of my answers down. So if you excuse me if it seems like I'm reading, but I really wanted to use this opportunity to get this information out there. So my passion for this work is deeply rooted in my lived experience as a member of the Hmong community and a first-generation American. I have seen firsthand how language barriers, cultural differences, and systemic inequities impact health outcomes. This personal perspective drives me to advocate for communities that are often marginalized in healthcare settings. And as a hospital board member, I see my role as a bridge between the community and the healthcare system. And I just want to reference the perfect words you use that is the blind spot, right? Ensuring that the voices of diverse communities are heard at the decision-making table. I advocate for embedding health equity and patient safety into strategic priorities by asking very critical questions, pushing for disaggregated data collection to identify disparities. My fellow board members will know I ask a lot of those questions, and championing policies that promote culturally responsive care. It's about holding the system accountable while fostering collaboration between leadership, providers, and the community.
Great, thank you. Dr. Sampath, I'm going to get you. You thought the political question was going to go, so I'm going to throw a little political question this to you. So infectious disease outbreaks, they're going to expose, exacerbate existing health inequities. How have you seen this play out in the work? What strategies have proven effective in addressing both safety and equity concerns? And is the recent measles outbreak some example maybe of this? There's the political part that's in there, because that's been the news reports that we had our first death from the measles outbreak in some time.
For sure. Thanks for having me on this panel. And hi, everybody. I'm Dr. Sampath. I'm the infectious disease doctor at UNC Health Blue Ridge, and happy to be here in this panel. So I guess the way I think about health inequities, I don't think anybody has clearly defined it. I think I would think about it as health equity being the opportunity of everybody to get care, or the opportunity of everybody to be able to live their healthiest life despite or without regard to where they come from, how far they have to travel, how much money they have, how much education they have. That's the way I look at these things. Your question was related to outbreaks, disease outbreaks, and how they affect healthcare disparities. I think the most recent, I'll get to the measles part of it later, but I think the big thing that we've gone through over the course of the last 5 years has been COVID-19. And I think we have very good data that says that simply put, COVID-19 killed more people, or the mortality was higher in places that were underserved, in populations that were poorer, in populations that were less informed, in populations that were crowded together in communal style living circumstances, and in populations that were not vaccinated. So, all this mortality is related directly to these social determinants of health. And so the outbreak of the COVID-19 definitely made the already existing inequities very apparent. I think measles is also, one of those things that ultimately has the potential. I think we've forgotten about vaccines in general. Before the polio vaccine, there were 15,000 cases of people getting paralyzed from polio. We don't see any more paralysis related to polio. There used to be children born with defects and congenital abnormalities from rubella. We don't see any of that. There used to be kids dying, about 1,000, 2,000 kids a year with Haemophilus influenza meningitis. We don't see all that. So we've forgotten about all that because of the vaccines that we use. And measles is one of those very dangerous diseases. I don't know if you all recall, when COVID-19 was spreading, we used to think about data like what is the R naught? So if you have one case of COVID, how many additional cases can you add? And so the R naught was around 3 to 5. Usually measles has an R naught of 18. One case can give 18 additional cases. So these are huge healthcare, emergencies. These are canaries in the coal mine, if you want to use that analogy. And I think that these outbreaks, if they become more pervasive and ubiquitous around areas, will definitely widen that healthcare disparity gap.
Hey, what are some key elements involving patients and partners in care? How can we ensure this approach is equitable across different patient populations?
Thanks, Danny. Anthony Frank, I'm the Chief Medical Officer for UNC Health Blue Ridge, and along with Dr. Sampa, spend a lot of time with our undergraduate medical students and residents, and really great to be here tonight. One of the things that I just kind of wanted to lead with, and as I'm working with medical students and residents, one of the ways that I like to teach is trying to present a moment and an image that somebody can implant in their brain that allows them to maybe stop or give themselves a couple of microseconds before they do something and think about it as they're getting ready to care for another human being. One of the most impactful things that I would tell you, and one that I've imprinted on myself, and I think the Colonel, hopefully he'll allow me to do this, I think if most of y'all can imagine what he described in the Walmart, in the hoodie, and the gentleman that he was when he walked into the hospital that day versus if he was dressed in a U.S. Air Force colonel outfit and he had been giving the same information to a healthcare provider, was there a difference in just the image of the way that he looked and was presenting that data? Would it make a difference of how we receive the data? And I think most of us sitting here thinking about that image would say, one, I'm going to listen to because he really looks like he's squared away, and the other one is just a family member. And so, again, I think trying to imprint that particular image for me to stop for a second, it shouldn't make any difference, right? If a family member or a patient is trying to explain something to me, I need to stop and make sure that I'm listening. As an emergency physician, I would tell you that you only have one chance to make a first impression. That's my practice of medicine. When I walk in, if the wrong one of me walks in that room, I've just missed the opportunity to establish trust with that patient. Laura's heard me tell this story, and it's actually true. I've done it. I've walked into a room and realized that I was in the wrong frame of mind to take care of this patient. For whatever the reason was, whatever I had just left, again, as an emergency physician, that may have been a pediatric cardiac arrest. It may have been a horrible trauma, but just not recognizing that I was not ready to take care of the next patient. And the me that showed up into that room and the interaction that started, I could tell that was not going well. And I've actually told patients and families, excuse me for a second, I need to step back out and start this again, if you'll allow me to do that. And bring a different physician into the room to establish that trust. Colonel Coffey mentioned a number of times today, and actually one of his parting messages to the residents was talking about partnership with patients. And I think the way that you do that, and there's a lot of data around this too as well, is as a patient starts talking or family starts talking, I think the average time to when a clinician interrupts them is somewhere between 18 seconds or so. And it's another one of those things that you almost have to pinch yourself to not do it, because there are all these things that are running through your mind about the next question that you want to ask, and obviously as that's going on, you're not listening to somebody, and it's pretty apparent that you're not listening. So all of that aside, you can always ask questions if you missed it the first time, but taking the opportunity to listen to what the patient or the family are telling you. And again, most of these people are not medically trained, and so you may have to put this into something that you know, but making sure that you listen to those patients as you're trying to take care of them.
Thanks. Carly, you ready for a question? So in your experience, how can the questions a patient asks serve as a tool of trust, improve safety, and reduce disparities in care?
So I think it goes back to something that we do in the military all the time, which is we train for situations. We test to make sure that we've got the right thing, and then we trust. And this builds on what Dr. Frank had mentioned about trust, because trust is built through transparency. Trust is built through transparency. The training that we do means that we don't just, it's not first contact when I run into a patient. I actually have to think about, what am I going to do? What's a different scenario that I may run into? When I had a tour of the hospital today, it was really refreshing to see a training room and see the nursing staff going through some training. It really made my heart feel good because we do a lot of training. We test and say, well, we did this a certain way and it resonated or didn't resonate. And we trust that through our training that our patients are going to be taken care of, that we're going to react the same way every single time. What I would tell everybody is that, in the military, I train so that I don't get it wrong. I'm sorry. Most people train so they don't get it wrong, or so they get it right, rather. People train so they get it right, but I train till I don't get it wrong. That's a very different way of thinking about it, and I'm going to say it again to make sure it's clear. Most people will train until they get it right. But professionals in this profession of arms, in this profession of medicine, we train and we practice and we test and we trust till we don't get it wrong. I don't worry about getting it right. I don't want to get it wrong. And so that means it is ingrained in you that when I look at this patient, I'm going to train myself not to be anchored in a diagnosis. I'm going to train myself not to have a bias because of the way they look or their background or what's below the waterline when you start to think about those social determinants of health that you just don't really see. The last thing I would mention about that is reframing how we engage our patients. And I mentioned earlier to the residents today about there's a difference between medical care and health care. Medical care, I come in, something's wrong with me, you fix it. Health care is more of an ecosystem. I've got an iPad, I've got an iPhone, I've got AirPods. It's an ecosystem. There are silos that are in medicine that we have to break down. So you talk about what's a tangible, actionable step. It's what's the thing that we have to break down? What's the silo we need to break down? What's the interoperability that we need to have between systems, between departments? Because those things happen, egos happen, right? When we look at healthcare as a system and a systematic approach, when the pharmacist is filling a prescription, when the doctor is writing out these orders, we're also thinking, what kind of social determinants of health impact that patient? Do they have access to clean drinking water? Because when I write your prescription, I just assume that you do. But we understand in Flint, Michigan, they still have bad drinking water. In Jackson, Mississippi, as of 2022, 2023, this is not a long time ago, there's still water issues that are there. Do they have food insecurities? Do I look at your zip code and say, oh, we know there's a food desert over there? And how does that impact you as you start to care for those patients? So we have to look at healthcare as a system and an ecosystem, not just the medical care of the transaction of me helping to fix you.
I'm going to play off that just a second as a follow-up. I'm going to talk to two physicians at the end. Yesterday when I was talking to the students in my lecture, I showed a picture of Dr. Sims, who was the health officer in Bay County, West Virginia in the 1940s. And he was getting into his Willys. You all remember what Willys was. And it was a vehicle that was meant to go up the hollers so that they could see patients in their house. We lost a lot when physicians didn't do house calls. They couldn't see the environment that the patient was in. They couldn't see the food not being there. They couldn't see, right now if I came in with something respiratory, you won't run me through 62 tests before you find out I have black mold on my house. But that physician can see that type of thing. How do you, with modern technology, and a 12-minute visit for a primary care physician, how do you replace, Dr. Watson said, how do you replace that so that you can understand what those patients are seeing without being in their house, in their life?
I'll start this one, and I guess you may have just picked up on one of my newer passions. So the way I describe this is I think we do in general a really great job of acute care hospital-based medicine. So if you come to our emergency department and you require admission to our hospital, I think you're going to get exceptional care, and we do a fantastic job of making sure you have the specialty care that you need during that hospitalization. On the other side of that, I credit to our primary care physicians, family practitioner, internal medicine in the clinics. I think if you make it to the clinic and you have the resources for transportation, money, gas, the other things, and you can actually get to our clinics, we do a fantastic job of coordinating your care and managing your health in those two places. But what I like to describe is there's a whole lot of space in between the clinic and the hospital. And I think what you're asking, Danny, the way this used to be, that space didn't exist quite as wide as it does now, because you would do a house call and you knew what the house looked like or whether they could get to the appointment. And so in the last couple of years, I really think that we're starting to turn an eye back to those opportunities. Public health, not just because you're the moderator this evening, but we've very much underfunded public health and the mission of that. I mean, the vaccines and all of the other pieces that you do is critical, but also, you know, all of the other work with surveillance and being a part of the community. And so with the combination of public health, we're starting to move in an area of community paramedicine, mobile integrated health, because those are the folks that actually know what those houses look like. Those are the people that we can actually send to see if there's mold on the walls, that can realize that there are carpets that older folks are going to trip over. And so, again, I think you're exactly right. The ability of us as health systems to start to really work a whole lot heavier in that space in between what is our primary care as well as what is our hospital care, and start to manage that space better.
Thank you, Dr. Frank. I'm going to ask a question that's general. Anybody wants to follow up and answer this? We talk about health equity, we talk about patient safety. At the hospital and health department meetings about this all the time. We have dashboards and spreadsheets. And they're often discussed separately. But we know they're every day. We know that. Can you share an example from your experience anywhere in the hospital about addressing health equity directly and how it improved patient safety?
I think language is one of the big ones for us, right? The need for interpreters, not just in the Hmong community, but within the Hispanic community here. We have, just right here in Morganton, we're about 20+% Hispanic, and not just that, a large majority of them are from Guatemala, with some people say different dialects, but they're different languages. And we have about 7 or 8 different Guatemalan languages right here. So first of all, stripping away some of our tropes and stereotypes that if you look like you're from Latin origin, that you speak Spanish, that's not true. Oftentimes it's a second language or a third language. Oftentimes even the children who we often rely for interpretation services do not speak Spanish fluently, and that can be applied across the board. Even I have a hard time interpreting for my parents sometimes. You know, I think the medical language itself is difficult enough, and then when you have to interpret words that don't exist in those other languages, then you start to just describe the symptom, or you describe, for example, diabetes. We'll say sweet sugar. Yes. So a critical part of addressing this health equity is also in recognizing that you have to take it a step further. You don't just provide interpretation, you have to make sure you're providing gender-specific interpretation. So for example, in some of our culture, and I use the Hmong culture a lot because that's what I know, that's my lived experience, but all of this you can take, duplicate, and tailor to other communities. My point is, there are certain taboos in cultures. For example, if you're female, you're going to a women's clinic, and you have some intimate issues, okay? If your interpreter was a man, a Hmong man, that's very problematic because in Hmong culture, these intimate details are not talked about, and so that may cause the patient to withhold information because they're not comfortable telling the interpreter. So keeping those things in mind, and I'm so proud of UNC Blue Ridge because the last time we were in the hospital, and I never tell people I'm on the board because I just want them to focus on my parent or whoever I'm with. And in the past, it's, do you all need an interpreter? And now it's, do you prefer a male or female interpreter? that's taking it a step further. And this was something that years ago, someone in my family did have an issue where they had some reconstructive surgery. They needed the intimate area, and the interpreter turned out to be a distant male relative. And after that, they could not, to this day, look at one another in the eyes at family gatherings. So think about these health equities, and beyond your doors and your world when they come in, the consequences that follow them afterward too. So thinking much deeper about things like interpretation beyond just providing the service.
So that, fantastic comments. I'll tell you, fantastic comments. I'm reminded of an experience of when it sort of changed for me, and it goes back to one time my son, we were in the hospital about 28 days. So this was probably the middle of a longer stay, but 28 days is a long time to be in the hospital. And we had rounds every day, and Colonel Coffee always goes to rounds. And so one day I come in, and there was a tech in there, and I said, hey, what time is rounds? And the tech says, oh, Colonel Coffee, we already had rounds. And I politely, professionally, but sternly reminded her, I've been here 28 days. Why would I miss going to rounds? Then they sent in a nurse. And I said, hey, what happened to rounds? And, oh, we already had rounds. And I politely, professionally, but sternly reminded the nurse, I've been here 28 days. Why would I miss going to rounds? Then they sent in the resident. And I politely, professionally, but sternly reminded the resident, I've been here 28 days. Why would I miss rounds? Then they sent in the attending. And he said, Colonel Coffee, I heard you have questions about the rounds. And I politely, professionally, but sternly reminded him, I've been here 28 days. Why would I miss going to rounds? I've not missed going to rounds since that day. Conversely, there was a patient that was right beside me in another room, and I walked to this person's room in the evening. And the reason I always, when I told this story to the residents today, I emphasize this, and I also want to make sure I tell it to some of our more seasoned providers, is because I knocked on her door because that is her space. When you come to my room to do your business with me, please knock. That is the only space I have in the hospital. That's my house. The friends and the family that you have when visiting hours are over become the nurses and the environmental services staff and the food and nutrition staff and the patient that may be in the bed beside you. And so I asked this young lady who was from Baltimore, Maryland. So if you've ever been to the DMV area, DC, Maryland, Virginia area, she's from Baltimore. So she looked like me, but she ain't look like me. She looked like me, but I don't have tattoos on my face. She didn't look like me. And so I asked her, I said, I've never seen you in rounds. And she said they never invited me to rounds. And in that moment, and this is where the light bulb clicked on for me, and I told her some advice, and I was so happy to see her the next day. I said, in this place, you and I are the exact same person. It doesn't matter about your educational, economic, social status, academic status. We are the exact same person. We are two concerned parents that's here trying to get answers about our child. And you need to make sure that you talk to the doctors and engage them and make them talk to you at a level of shared understanding so shared decision-making can happen. So the next day I see this patient, and she's out there talking to the doctors, and they're talking way above her head, and she pushed back. And so what it reminds me of is that the bias and the anchoring that we have because she looks a certain way. What I found out later is that she really just wanted to go home because there's healing that happens at home, but she didn't have a car. And her child had to come back because he had transplants as well to get cytogam infusions, and there's no way you're going to take a child who is post-transplant on a train, a metro bus, and then walk to the hospital multiple times a week for these life-saving infusions. You just can't do it. But she, young mom, just wanted to be home. So when we start to think about how do we engage, and when we talk about these ideas of diversity and these equities and these inclusive things, we have to be very deliberate in our approach. And I would say, I was doing a tour this morning, and I think I said probably 50 times, you guys are very deliberate in what you did in building that hospital. You're so deliberate. I applaud you, Mr. President, for all the things you've done, because when I walked into the room and I saw the couch, the sofa, because I've slept on those things, it looked really comfortable. It looked like it was done with intention. When I saw the restrooms and how well they were lit and how nice they looked, when I saw where we placed the nurses and said, you've got 2 patients with line of sight for both of them. I've got a board that's in the room that tells you who your service team is, who your provider team is, so that me as a patient feels empowered with information. You do things deliberately. That's how we start to get after breaking down, the challenges we have with diversity, equity, inclusion, and culture. And the last point I'll make about this culture piece, as a military officer who's led hundreds, if not thousands of people over my 20-plus year career, culture will beat strategy every single day. Culture will beat strategy every single day. Every leader here is a thermostat. You're not a thermometer. Thermometers just take the temperature. So when I talk to the residents, you're not a person come in to take the temperature of your team. You're a thermostat who sets the temperature and the tenor and the tone for everything that goes on in your organization. Colonel Coffee comes in and has a bad day, everybody's having a bad day. Everybody having a bad day. So that's how we get after culture.
I don't think I heard a few amens in the back, but so Dr. Sandman, after hearing what you just heard, you have a lot of responsibility to train the next generation. The next generation of physicians that are coming up. They look to you for guidance. How do we build what we're talking about in terms of cultural competency, and still keep patient safety, and still keep the training in terms of what they need to know, but also what they need to know about that patient, you as a person? How do we balance those 2 things and make sure that the medicine is there as well as the cultural competency?
Yeah, so great question. So, we do have a great training program, and thanks for all your support for that program. I think as trainees, a lot is thrown at our residents. They have 3 years of intense training in many, many different domains. And one of those domains is understanding what social determinants of health are, understanding what healthcare inequities are, how healthcare inequities ultimately lead to patient safety issues. If I don't have time to spend with that patient who's not fluent with English, with an interpreter, I'm not going to get the right history, or I'm not going to be able to communicate the importance of taking a medication a certain way. And that's going to lead to patient safety issues. These are all connected things, but they're quite complicated. It's a web. To disentangle that web and to explain it to the residents, I think some creative learning strategies have to be employed. So that's one of those things. So simulation-based, case-based, or actual event-based analysis, which is something that we do actively in various forums. So that education part of it can be focused in a very structured way rather than an unstructured way in which they get a feel for these issues as being issues, but too complex because they need to treat diabetes before they understand what healthcare inequities are. But I'd argue that both are exactly related, connected, and they can't be disentangled. Your medical knowledge cannot be disentangled with your intent to deliver it in a way that it actually has its intended effect. So in addition to education, I think leveraging technology may be useful, simulations. I think understanding the core behind why these inequities may exist is important. Biases come into play over there, understanding that we all do have some biases that we may not be aware of. It may come into that segment where other people are aware of it, but I may not be aware of it, or nobody's aware of it. And ultimately, I think it's challenging and it's exciting to deal with people who come in unbiased into a learning environment. And I think we have to believe what we teach. I think we get to believe what we teach when we have data, like you said, data. And I don't think it's until recently that CMS has actually required us to track social determinants of health so that we even know, hey, you know what, if I never knew this patient was homeless in the first place because it's not showing me on the chart that the patient is homeless, why would I be interested in asking questions like, hey, do you have transport home? Or do you have a place to stay once we discharge you? How are you going to do your wound care with that wound on your leg? And then once we realize that, oh my God, this patient has all these needs because we've gone that extra step, we've been sensitive to those aspects of care, the next question is, how are we going to leverage our resources administration. How are we going to leverage resources to get that care to that patient, get that transportation, get the gas in his car, get the dressing supplies to his or her house. So, untangling this complicated web of highly interrelated, important concepts that are all very relevant to care is part of the challenge of training residents, because if we do it wrong, people suffer in the end.
Thank you. Carl, I want to come back to you.
Danny, if you don't mind, I'm just kind of add on to that. And so an interesting point in thinking about what Dr. Sampath just said, just from a personal standpoint, growing up, I had everything that I needed. It was, there was not a night in my growing up that I worried about having clothes or food or, any of the things that we would consider. My parents could afford gas for the cars. I went to a nice school. We lived in a nice house. And as you progress through what it was, I knew I wanted to be a physician, high school, college, med school, residency. You get to the end of that, though, and the folks that you're taking care of did not necessarily have the same life that I did. I don't even know that I would have understood to ask the question about where did you stay last night, or do you have enough to eat? It's just not, it's not a frame of reference that you had to do that. So again, it does require some instruction, as Dr. Sampath is saying, to maybe understand that not everybody was raised or had the same experience that you do. I want to tell you a quick story that, again, just another one of those very impactful moments in my career. I was in academics at East Carolina University, and on Wednesday we had conference. There was a shift that had started at 11 a.m., so usually you had the opportunity to go to conference for a little bit, and then you came downstairs ahead of the residents. So it was just attendings running an academic emergency department. If you want to be scared, that's scary. But I can still picture it. The two sides of the emergency department, there's a P side and a G side, East Carolina purple and gold, in case you don't get the reference there. But it was on the P side, and in room P49, I can still see her. She was about a middle-aged African-American female, and she was there with chest pain. And she was the first patient that I picked up by myself, went and saw this patient, and walked in, introduced myself, took a history, did the physical examination, told her what I thought we needed to do, and as I was leaving the room, she said, thank you. And I said, well, you're welcome. And I turned around and I stopped for a second. I said, thank you for what? And she said, thank you for being so nice. And it was a new bar setting for being an emergency physician. The baseline of what another human being cared about was just my being nice. And it only gets better from there. So if you can train residents, we're going to give you the medical knowledge, we're going to teach you how to do procedures, but can you just be nice to the human being in front of you?
Thanks. Colonel, I want to come back to you. So your career is kind of interesting. You got this small organization you do a little work with, patient safety. And you got this little bigger organization that has a weird shaped building next to it. Pentagon's a weird shaped Department of Defense. So can you tell us a little bit what kind of lessons you might have learned working within those two organizations that we can apply to the civilian healthcare system?
So, I do a lot of reading, and sometimes it's not just medical stuff, but I live with a lot of military reading as well. And there's a book I read called The Kill Chain. Now, I know that is not normally a title that we would sort of associate with medicine when we talk about killing things in the kill chain. But I think if you look at the kill chain as a systematic way of approaching problems, it makes a lot of sense. And so within the kill chain, there's three parts. You have to understand the issue, you have to figure out and decide what are you going to do, and then you have to go do it. And so when I look at that in the context of medicine, understand the issue. There are disparities in care, there are social determinants of health, there are people that have inequities. We know what the issue is. We have to decide, what are we going to do about that? And then how do we make this decision? After we've made a decision, how do we actually implement that? And so what I will tell you is that in the military, we organize based on a capability or need that we have. And so I would say the same to medicine. How are you reorganizing to meet the actual challenge and the needs that are out there? If I need to go, and I'll just in military terms, if I need to go make sure that I'm ready to go fight China because of the projected war that's going to start here in the next number of years, I need to make sure I've got all of these military assets in place to be able to defend the country and defend Taiwan if that's where the point of aggression starts. If I know that I have a population that is being served in medicine in my hospital that is so underserved, what am I doing to try to address that need? And so the thing that I would say where this nexus of what I do in the military and what I do in patient safety is I try to find out how do we reorganize, how do we build to the capabilities and the capacity that we have, how do we build to that capability that we need to fight the fight that we're going to have tomorrow. And so a lot of times, we talk in sort of two ways when we say that, because we always want to prepare for the fight for tomorrow, but we also have to be prepared to fight tonight. Meaning I have to always take stock and assessments of what are we doing now if we had something go off, right now. What am I doing now in my hospital to look at those patients, to look at those people who are underserved, those underserved populations? What are we doing now to actually put meat on the bones and serve that population? And if we're not doing anything, then we need to change. We need to reorganize. And again, one of the things I had mentioned before I derailed myself was I was so impressed with the dedicated space in the hospital for behavioral health. That is so huge. And I will tell you, I have been to hospitals around the country from California to Florida and everywhere in between. And I've not seen as many hospitals, or I've actually seen a hospital that had a dedicated focus for that. So I applaud you, and I'm going to take that back to DC and say, hey, what are y'all doing over here? Because I know a hospital down in Morganton, North Carolina that has kind of figured its thing out, right? But that's a population that we need to also think about. That's what I think we have to do. We have to really start to reorganize and retrain and refocus on what is the fight we're going to have for tomorrow.
Thank you, Carl. I love that Southern Tennessee accent comes out. You sound more like us than the rest of the DC guys. So take your acting out. I want you to put the board out. From a governance perspective, how can the leadership ensure that health equity and patient safety are embedded in all the decisions that you all make and then make your way down to the other parts of the hospital?
That's a great question. First of all, when I was asked to be on the board, I was like, what? Why me? I always feel like a sore thumb sticking out, but you'll find with these boards how important it is to have a voice at the table. There's a difference between being asked to be on the board and you feel kind of tokenized being a minority. That happens a lot. But I have found that on this Blue Ridge board, my opinions and my questions are taken very seriously. First of all, I think from the executive team all the way to the board, we have to set the example by empowering our own teammates. We want them to connect with our patients and bring them in as part of their care plan. We have to empower our teammates to do that. We have to give them the voice and the agency to do that and the training. So I would say we must adopt an equity lens in every decision that we make, not as an add-on, but as a through line, as a core part of our strategic framework. And that, again, takes commitment from the board, and it takes commitment from all levels of leadership. If we prioritize equity alongside patient safety, we look at KPIs and all of these data points, so we're focused on what we're looking at. What are the things that we're not looking at that's not showing up? That we should be focused on. And then the other thing is we need to leverage the resources that we have here. Dr. Sampath, you mentioned leveraging. You know your demographics in this region. Use them as a resource. Duplicate those programs, tailor those programs, then you can serve. You can say you're able to serve the majority of people, you're able to break down barriers. Are we asking the same questions we asked 10 years ago, 5 years ago? If we are, something's wrong. We're not making progress. So, do you know that, back to the Hmong community, if you really wanted their input, you have the 18 clans here. There are 18 clans. There's leadership in those clans. They bring the entire Hmong community together. Are you in those spaces? You have St. Charles Catholic Church, serves our Latin American, Hispanic Americans here. Are you in those spaces? You have New Day Christian Church, African American Church, very active in mentorship in the schools. Are you engaged with them? So I think we have to look at, from the leadership perspective, about where our people can be more engaged and how we empower our people to become more engaged.
I'm going to ask one more question that anybody can pop out on, and then I'm going to turn it into just no more softball questions. I'll recognize some kind of questions. So, technology is a new thing. Everybody's invested in Amazon, Apple. I've got a couple of 20-somethings who really don't know what life was like before the iPhone existed. But in the hospital, we got more toys than we know what to do with. What are some ways we can use that technology to both enhance health equity and patient safety while ensuring we don't provide disparities for those who don't have the access to the same digital tools or the analog too?
I'll start it with just one of the things that I think a lot of our primary care physicians and physicians in general are really excited about, and that's the ambient listening related to AI. And for those of you not in healthcare, there's actually two different ones. One's a Microsoft product called DAX, and another one is another company that's actually, I believe, sponsored some by NVIDIA, and it's called Abridge. UNC is going to be implementing the Abridge version of the software, and what this does is it actually allows AI to listen to the encounter that the physician is having with the patient and the family. And the way this actually works is it strips any of the niceties out of it. So we could sit there and talk about your kid's softball game or the trip that you just took and go through the pleasantries of all of that, and none of that gets documented in your health record. When I start asking you about how you're feeling and how did the test go, or why do you think your ankle hurts, it starts picking up that, and it listens to the exam that I do. And meanwhile, I'm facing you as the patient, having these conversations like it should be, and I'm not worried about having my back to you while I'm documenting on the computer and typing away on the Epic. And the hope, again, obviously, this is supposed to start in primary care, and one of the big hopes there is that it's going to reduce something called pajama time that a lot of our primary care physicians experience. And this is what you get when you have a very busy day in the clinic and you didn't have time to document all of the encounters and labs and everything that you did with your patients. And you go home and you have dinner with your wife and you help your kids with your homework and you do baths and you put everybody to bed, and then at 10 o'clock at night you pull up the electronic health record and you start doing the day's work. And so you can imagine the work-life balance that creates for your physician, and just the constant strain of never disconnecting. And so I think the benefits in healthcare of having your doctor look at you and have conversations with you about why you're there, with that being picked up into the electronic health record, so we're reducing the amount of time, I think is a huge positive. So that's what I'm really looking forward to.
Technology is really interesting. I have the privilege of I'm in that generation where I grew up without cell phones, and then bam, cell phones hit. I still remember the card catalog system in the library, things like that. So I get to live in those two time frames. But technology is great. Depends on how you use it and if it creates other barriers. So one of now this is a feel-good story because I shared this in our Connect to Purpose in our last board meeting, which is my mother, my beautiful mother there, was recently hospitalized, and I took her to the ER here at UNC Health Blue Ridge, and she had to have a CT scan. And in the past, with my dad, when he's had to do a CT scan or some type of scan, I'm between the door, a little slit, yelling, "Hold your breath. Take a breath, breathe normal," not even sure I'm interpreting it correctly. But this time, the lovely technician said to me, I said, "Well, where do I yell out of?" And he's like, oh, what's her primary language? I said, Hmong. He was like, "Our teammate April has recorded instructions. Put it on. She hears it, tells her to hold her breath, breathe normally, etc., etc." Afterward, we were tickled. This was the first time that's ever happened. And I asked my mom, I said, "Did you understand April's instructions?" She said, "I understood her perfectly." That is where technology is really beneficial, because now me as an interpreter, I don't have to worry if interpreting correctly. And then at the same time, as the patient, she felt heard and seen. They have her language giving her instructions. Where technology doesn't work, for example, is I think Epic's great. I can access my UNC chart, my lab results, etc. Can my parents by themselves? No. It's not user-friendly. It's not in their language. It's hard to navigate. So in some ways, technology benefits. In some ways, it doesn't. And there's still, in some ways, it can create more barriers.
We'll take a couple questions. Who has one? Really, this one needs a shot? I can't get Sean Ham to shut up. He's a medical director in the health department. I get to pick on him. We've got a question right here. Hold on just a second. Let Lauren get the microphone to you.
How does profit-driven medicine, how does it interfere with better outcomes in patient care? That's the way.
Pass on that. You all know.
See, that's the 12-minute patient interaction.
Yeah.
The primary care doctor.
I think it's one of those. Now, from my perspective, obviously my focus is more on the health equity aspect and diversity aspect. And then that's also where different perspectives on the board happens because they come from the finance world, business world. And so really having this 360 oversight, including the financials of the hospital. But I do think those, did you say 12 minutes, 18? Right. So that 12-minute visit makes a huge impact that will affect the future outcome, financial outcome of the hospital. I'll give you a really good example. We had an experience with an awful doctor who talked down to my father like he was a child, okay? And I was younger, much more temperamental. I saw red because my father, who is a survivor of war, who managed to escape communism, escape death, bring our entire family here, worked until his health couldn't allow him to work anymore. He was being talked down to like a child, okay? They lost our business, okay? You want to talk about financial impact? Those 12 minutes, they lost their business. Guess what? These communities are very tight-knit. It's not just the reputation of the doctor now, it's your whole system. That goes through communities. That has financial impacts in the short term and in the long term.
So I'm gonna give one quick thing. That is a really tough question, and I'd mentioned to some other folks in a smaller group that if I could rail against one industry, it would be the insurance industry, because I believe that every single health provider gets into medicine for this altruistic spirit of I want to spend time with my patients, but I am forced to only give you 12 minutes of my time because I have to write notes, and insurance is going to dictate what will and will not be covered. I recall a patient that was at the hospital with us when we were transplanted, and this is the early days of transplant, and this person was on Medicaid. And I remember, one, I helped her get a GED, which was like, I'm going to pat myself on the back for that one, because we studied in the hospital, and it made me feel good to help her, and it made me feel good when she got her thing. But I remember the times that we were talking, and she said, I had to make this decision between something that might help my son and something they know that is working right now, and it's going to be on in perpetuity because Medicaid won't pay for both. And here I am sitting with TRICARE, here's my ID card, don't spare the MRI, you know, and she has to make this decision about care based on what's going to be covered. I think the challenge that we have to always remember, and this is where that balancing act comes in, is that medicine has been and will forever be a people business. And we cannot allow things that you said earlier, I love that, don't let your technology create a new barrier, but we cannot allow things like insurance to become this barrier for care. So when I'm talking to C-suite leaders and CFOs in hospitals, I say, well, here's why patient safety is important to you. Because if you focus on inclusion of patients, if you focus on equity and diversity and really looking at those social determinants of health, it's going to make the hospital money because it will save you in litigation. And so when you start to tie those things to financial gains, because even though medicine is about helping and healing, it is also a business. And if the hospital closes, we don't have money to run the hospital, which means we can't heal and help people. So there's this balancing act of that. Yes, sir.
We got a question over here.
Hi, thank you so much. My name is Dr. Monique Bethel, and I'm here from the UNC Health Shared Services. And the question, actually I have many questions, but I'm going to try to find one. The question that I wanted to really ask is, given the current state that we are in right now, what policies need to be in place in order to prevent the lack of dis and misinformation from federal agencies? And I say that particularly because we're dealing with measles, we're dealing with just the lack of information, the potential for not getting information. How can that make disparities larger? And what can we do from an equity perspective?
Is it because I'm from DC and I write policy? Is that's why I get this? So I'm going to navigate this very carefully because this is a recorded thing. So I think the first thing we have to understand is that to combat disinformation and misinformation it's a full contact sport. It requires us to be present in the communities so that people can see and experience with their own eyes and their own experiences and their own thinking, vice what they're being told through whichever form of news or media that they consume. Because oftentimes what you find now is that people will go to news sources for confirmation, not for information. And so this is where we have to go back and say, for us to really change and do something, it requires us to be at a very grassroots level of saying, I'm going to be in the community. I'm going to go into the Catholic Church to go get to this population that is underserved, that may be getting misinformation. Policy-wise, it requires us to go back and I say from, the tactical level, as we would say in the military, the thing that you have to do, it still requires us to engage with our elected officials, because at the end of the day, what makes America so great, and having been to a number of other countries, it's the fact that we're a democracy. Good, bad, or indifferent, we're a democracy, and that we still believe in the rule of law to the extent that everyone still has a voice and a chance through your vote, through your engagement with your elected officials at all levels to make real, significant, and tangible impacts. The other thing that I would say is the educational piece of what we can do on the local level is much more impactful oftentimes than what you will find at the national level. And this is where I found that people sort of think, I only can talk to the folks in DC because they're going to make the most impact. And I remember going out to Iowa one time, and literally I gave this brilliant response to this doctor in Iowa of how you fix this problem. And during the break they said, you do realize we only have 2 hospitals in the state that actually can do what you were talking about. And I'm like, okay. DC mindset of I've got plenty of choices of hospitals to go to. And so really understanding that the local impact is how we make the largest impact and impression upon people, and that's how we change the policies.
All right, we got one more question. Dr. Hand, we'll give it to you to finish this out.
All right, thank you so much. Colonel Coffey, thank you so much for being here with us this evening. Sean Hand, Family Medicine, and the Medical Director at the Burke County Public Health with Danny. I have a question for you specifically. Thank you so much for connecting DEI and equity with patient safety tonight. It's so important. With the new change in the position on DEI in Washington, D.C., how has that impacted your mission and your message about patient safety, and specifically about patient safety? And what advice do you have for us here at Morganton, North Carolina?
I can sum it up as the advice is that it still matters. That is really the answer. It still matters. I will tell you from my professional hat, it has been a whirlwind of change. And I had mentioned to folks earlier that change happens irrespective of who's in the White House, whether it's the same party or a different party. Change happens. I've lived through a number of presidents. The pace of change under the current administration is one that's causing us to somewhat put head on swivel and trying to react to things. If I were looking at it from a military operations standpoint, this is the shock and awe that we experienced when we went back into Iraq in OEF and OIF back in the early 2000s. So I go back to the fact that it still matters. But I think we have to connect both head and heart to the things that we're doing to really get the message out that it still matters. Connect the head to the heart. I give an example. I am writing policies now about how do I then implement executive orders that would somewhat turn a back on those transgender service members. And I know transgender service members. And so when they start to think about these broad statements of like, get rid of DEI, get rid of transgender service members, there are many, many tertiary and quadrennial levels and effects that have to be also thought about. How do I give you medicine when you have to take hormone therapy for this? In perpetuity, what do I do? What's the VA? What's the DHA, Defense Health Agency? What's their role and responsibility to take care of me, a veteran, once I'm in or out of the military? And so I would say that again, when we start to connect that head and heart together, when we start to see people as people, then we start to understand that, yes, DEI still matters. And that is something I keep in the forefront of my mind. I do have to do it a little differently, but it is never out of my mind that it matters. And it matters in patient safety even more because, again, people, when you come to the hospital, it is a significant emotional event. I go to the Pentagon every day, 26,000 people that work in that building. You come to your hospital every single day. I see how cold and sterile the walls look. You just forget about it. I go to the Pentagon, I don't even care that we have Starbucks and Dunkin' Donuts on the same floor competing to see who makes the best pumpkin spice latte. And they are. So really understand that when that patient comes in through those sliding glass doors, it is a significant emotional event, that they are concerned, they have anxieties about what they're seeing and hearing in the world, and they come to you at their most vulnerable point in life and at that time when they are sick. So it still matters. That's why I said my whole answer for it, it matters.
Thank you all very much for coming this evening. If you will donate some of it tonight, it is going to be sitting outside Laura's office, or we're going to snack on for the next 2 days at the hospital. Please take your time, enjoy yourselves, mingle amongst each other, enjoy some of the food that's there. Thank you for coming.